Good evening. I'm Hartford Healthcare's Tina Verona. Thank you so much for joining us for another live Facebook discussion. Well, prostate cancer is the second most common cancer among men other than skin cancer. So we're going to be talking about prostate cancer as well as a very important walk-run race coming up on June 10th. But first, joining me now live is Dr. Stuart Kesler. He is a urologist at the Hartford Healthcare Tallwood Urology and Kidney Institute. Thank you for stopping by and sharing some time with us tonight. We appreciate that.
My pleasure. Thanks for having me.
Sure. So first, let's talk about prostate cancer real simple. Some men don't exhibit signs or symptoms of prostate cancer, but others do. And what are those signs and symptoms that they should be looking out for?
So, as in our prior interview, most men don't have signs or symptoms. So that's a good thing, but it's a double-edged sword because some people won't know that they have the diagnosis. And that's not unlike a lot of different cancers. But if you have an advanced type of prostate cancer or a very high volume prostate cancer, sometimes that can lead to certain symptoms, and that can lead to a slowing of your urinary stream, sometimes blood in your urine, and sometimes for advanced disease, even bone pain.
Let's talk about who's at risk of developing prostate cancer. And you mentioned something, we were talking earlier, you mentioned something so interesting that I found was that the BRCA1 gene, we associate that with women in breast cancer, but if that BRCA1 gene is in your family, it's on the women's side breast cancer, but on the men's side it's prostate cancer. Talk to us about that. I find that interesting.
Yes, I don't know if we know exactly all of how it relates, but we do know that families that have breast cancer that's related to the BRCA gene, that for men in those families, if they inherit the BRCA gene, they actually have an increased risk of prostate cancer. It's actually more the BRCA2 gene than BRCA1, but it seems to be associated with both BRCA genes.
So to those families that has that BRCA1 gene, what do you say to men in those families? Because we hear so much about breast cancer, but we don't hear about the prostate cancer aspect of it.
Right, so most people don't know if they're BRCA positive or BRCA negative.
Right.
So it's not uncommon for me to have patients, and when I ask a family history and I hear about breast cancer, I often ask, do you know if your mother's breast cancer was BRCA positive or not? So sometimes they have to do some digging and call their mother's oncologist and find out some details about whether it was involved. And if it was, then that does increase their risk. So part of the whole history taking is to assess one's risk, and so that's kind of one more piece of the puzzle to determine their risk and how aggressive we might want to screen that person.
For people like that, do you recommend genetic testing?
Correct. So if someone has BRCA in their family and they have prostate cancer, that's correct. We would want to do genetic testing because that might increase the risk of their sons or grandsons having prostate cancer in the future.
Sure. If you just joined, we are talking to Dr. Stuart Kesler. He is a urologist at the Hartford Healthcare Tallwood Urology and Kidney Institute here at Hartford Hospital. There is a very important event. It's a walk-run race happening on Saturday, June 10th at the brand new Dunkin' Donuts Park, home of the Yard Goats. That's happening there. Tell us about this. Now, you participated last year. This is it's a family event, and it's a way for people to come out, run, walk, participate, volunteer, do whatever, but really to raise awareness for money to go toward research of prostate cancer. This is such an important event.
Yeah, it's been done for many years for breast cancer, and I think finally someone woke up and said, hey, men tend not to be as proactive as women for their medical care. And someone said, why can't we do something like this for prostate cancer?
Right.
And so the Zero organization, a national nonprofit organization, picked up on it and started doing these types of races around the country for the last few years. And so this is the second year that we're partnering with them. Last year I ran in it, my son ran in it. It was a lot of fun. It was a little cold though. I think it was in February, so
that's right.
That was particularly a cold
Hopefully
day.
It will not be cold in June this year.
So hopefully the weather will be better. But and it was really great. I saw patients of mine. I saw families. It was really nice to have that personal connection. My younger kids ran in the little dash that they had there afterwards. My son at the end was, as I was huffing and puffing, said, "See you, Dad," and he just finished the race. So it was really a lot of fun. They give out free T-shirts and all that type of things. And so obviously the goal is to raise awareness. The goal is to raise money as well. 94 cents of every dollar that's raised through Zero actually goes to these specific items. It's not used just for kind of paying salaries or whatnot. So it's
Right.
really very efficient when you look at how they use their money. And it raises money for prostate cancer research. It raises money for community programming and educational events that we do in inner city, et cetera. So I think it's a great program.
Yeah, and last year it was a success, and so this is our second year, and we're hoping for another successful walk run. So we do encourage you. You do need to register. There is the website on your screen to go and register. You can, you don't even have to run. You can walk. You can volunteer. You can do whatever. But it really does create awareness around prostate cancer, because as you said, we hear a lot about breast cancer, but we don't often hear about prostate cancer. Let's talk about the diagnosis, because really when you're talking about prostate cancer, this is, as you mentioned, this is not a one-size-fits-all diagnosis. This is very individualized. Expand on that.
Yeah, I mean, it's something that we really, and I focus on whenever I have any patient, whether it be a diagnosis of an elevated PSA, which sometimes leads to a diagnosis of prostate cancer, but not always. And we really look at the individual. We identify what their risk factors are. We talk about what their age and other medical problems are. We kind of put that all in context of their diagnosis.
Now, the PSA test, we often hear controversy surrounding that. The U.S. task force comes out with guidelines every year. They sort of go up and down. It can be confusing, but the PSA test is still considered the gold standard in screening for prostate cancer. Is that right?
It is. At this point in time, it is the standard blood test utilized to help screen for prostate cancer. But there are other tests as well that we use. I know you have another question, but there's a 4K score test, which is a 4-protein panel, if you will, that incorporates PSA and some other proteins that can be a little bit more specific at times. There's a urinary test that we sometimes use. There's something called a PHI or PHI score, prostate health index score, that can also be used. So there are different blood tests that are starting to be developed that can maybe even be a little bit better than just PSA alone. And under the right circumstances, I think can be helpful. But I think that the standard, as you said, is still in general to utilize a PSA test as part of that process.
Right, and even if you are utilizing some of these other testing measures, you still would use the PSA test, but you're using this in conjunction with that to perhaps get a more accurate reading?
True, and again, these other tests that I mentioned, actually some of them have PSA in them. So PSA might be one of the 3 tests that they incorporate.
Okay, so we do have a question from Carol Ann. She says, my husband's father was treated for prostate cancer. Is my husband at risk?
So yes, the simple answer is yes. I mean, all men are at risk, to be fair,
Yep.
but I think the question is he at increased risk compared to the average? And so if that woman's husband's father was diagnosed with prostate cancer, it probably does increase her husband's risk. Some other important information sometimes, though, to kind of look at is how old was the gentleman when he was diagnosed with prostate cancer? If he was 85 years old, her husband's probably not at significantly increased risk. If her father-in-law, in this case, was 47, that would be much more concerning, because the age at diagnosis can affect the likelihood of it to be running in families.
And now Carol Ann has a follow-up. She says if he is at risk, which he might be, when should he start being screened for it?
So that's a little bit more complicated, because there's a lot of controversy over screening. It's a great question. It depends, to be honest, on who you want to follow and who you want to listen to.
Right.
So that's changed a little bit. It also depends on race, because if someone's African American, sometimes I'll recommend screening about 5 years or so earlier than average, or 5 years perhaps earlier than that family member might have been diagnosed. So in general, if you look at the American Urologic Association recommendations, they recommend starting at age 55.
Right. Carol Ann, thank you for that question. That was a great question. And brings me to my next point. Carol Ann sort of writing on behalf of her husband. We see this. We see this with men don't really want to...
It's because he's with the family right
He's
now.
taking care of the family.
Dinner.
Yes.
And,
okay. You're right. You're right. But we do see this, where the women are sort of the caretakers, and men don't really want to deal with this. And a lot of this is really education. And, maybe the PSA test, maybe there's some confusion about the numbers, and men just think, I don't want to deal with this. I feel great. Why should I deal with it, right? What do you say to those men?
Listen, there's no question that gender plays a role in how we think about our health. It does play a role in how we think about our care and our longevity to some extent. And women tend to be better patients. They take things more seriously. They follow up. They keep their appointments, et cetera, et cetera. And thankfully, they're there to support men.
Right.
We know actually that men who are married tend to live longer, and perhaps this is part of the reason why.
Of course.
You know, they maybe a healthier lifestyle. They seek medical attention. So I see it all the time. But I think it's about time that we caught up a little bit,
Right.
and we learned a little bit how to take care of ourselves,
Right.
and to look out for ourselves a little bit. You know, a lot of men out there are, single, divorced, spouses pass away, and so we have to be a little bit more
They
proactive.
don't have that support system or that sort of cheerleader behind them, right?
True. I mean, they can get support system in other ways as well,
Sure.
not just the spouse, but absolutely.
Yeah. So let's talk about the PSA test and some of the readings, because I think there is some confusion out there. Just because you have an elevated PSA test doesn't necessarily mean that you have prostate cancer. Is that right?
That's absolutely right.
Yeah.
Yeah, I mean, that's a common myth that we see, that someone has an elevated PSA and they assume they obviously have prostate cancer. Those are not synonymous. Depending upon their age, what their PSAs have been previously, perhaps even their size of their prostate, all can factor in on what perhaps their PSA number could be. Some patients have very large prostates, and that might increase their risk of having a higher PSA. It doesn't always follow exactly that way.
Right.
Some patients have small prostates and have low PSA, so it can vary. But there's no question, just having a high PSA does not equate to a prostate cancer diagnosis.
And sort of break it down for the audience. What is a high level of a PSA? What's normal? What's low? Break it down for us.
So, based upon the earlier data by a name Dr. Catalona, from Chicago, his data originally on PSA, anybody over 4 was considered abnormal. And if you had a PSA approximately between 4 and 10, you had about a 25% risk of having prostate cancer. Over time, we've learned a lot, and we found that it's hard, again, to kind of put everyone in the same box.
Right.
Some people, if their PSAs have been 3.8 for the last 8 years, and all of a sudden they go to 4.1, that 0.3 rise, does that all of a sudden equate to prostate cancer? Probably not. So the rate of rise and rate of change from where their baselines are have also been important. So I diagnose patients who can have a PSA of 2.5. You say, well, I thought 4 is abnormal. Well, if the person's PSA has been 0.8 for the last 7 years and all of a sudden goes to 2.5, that's a little bit of a red flag that something could be going on.
So a lot of it is that comparison of that PSA testing and really seeing what that trajectory is to see if it's elevated, if it's remained the same, and that would probably determine whether they go on a watchful waiting status.
So watchful waiting is a term we use more for a diagnosis of prostate cancer.
Right.
So what we were just discussing was more for an elevated PSA.
Right.
So just want to be cautious when we use certain terms. It usually means there's a diagnosis of prostate cancer. So I would say more so that under those circumstances, we'd be monitoring their PSA at different intervals.
Right.
Watchful waiting, just to shift gears a little bit, is a term. Watchful waiting is really where usually we use it in someone who's more sickly or very elderly, has a very relatively shorter life expectancy, and whatever the disease process that they have related to the prostate cancer is less likely to affect their life expectancy.
And I'm sure you take other factors into consideration there when you determine whether it's watchful waiting or active surveillance, like if it's an older gentleman, medications, other factors what are some of the other factors that can contribute to that?
So really
An elevated PSA test.
Yeah, so I think really it's related to, in particular if they have a diagnosis of prostate cancer and trying to determine treatment or not treatment. So obviously we break it down into their prostate cancer factors and then their non-urologic medical factors. So obviously there's higher risk and lower risk disease for their prostate cancer, and then we also have to look at their medical issues. Do they have a history of a heart attack? Do they have a history of a stroke? Do they have valvular disease and heart disease, et cetera, et cetera? Are they diabetic? How well is their blood pressure controlled? Things of that nature.
We are, of course, talking with Dr. Stuart Kesler. He's a urologist at the Hartford Healthcare Tallwood Urology and Kidney Institute here at Hartford Hospital. There is a very important walk-run race coming up on Saturday, June 10th, as we've been talking about at Dunkin' Donuts Park on June 10th. It's really a great way to support prostate cancer survivors or patients that have been newly diagnosed. If you know someone, or perhaps you were recently diagnosed or have prostate cancer, it's a really great way to educate about prostate cancer, because we don't often hear about prostate cancer. And I think there are some myths out there that men are either afraid to deal with it, or it's the fear of the unknown. Do you find that too? Because there's so much out there that they don't know about, or they maybe not want to deal with.
Yeah, and some people do prefer to stick their head in the sand. They rather not know than know.
Right.
And for some individuals, to be honest, who are very unhealthy and who have a lot of other medical issues going on in their lives, maybe a diagnosis of prostate cancer really is not in the cards for them or necessary to know about. One of the most common misconceptions or myths that I get when seeing patients with elevated PSA is, will a biopsy cause my cancer to spread? We hear that pretty regularly. And there's no evidence of that.
Right.
There are some very aggressive non-prostate cancers where actually a needle biopsy perhaps can have some effects. But as far as prostate is concerned, that's never been able to be shown.
Yeah, and now some other screening measures are MRI too, that is used for screening for prostate cancer. Tell us how that actually works.
Sure. So there's, to my knowledge, and maybe there's some clinical trials you might be aware of, but I don't think of MRI being used particularly just for screening. Usually screening for prostate cancer is done with rectal examinations or a blood test known as the PSA. But we do use MRI for other aspects of monitoring. So if someone has an elevated PSA that's persistent, they've had a biopsy and the PSA is going up and their biopsies don't show cancer. Sometimes we feel that doing an MRI might highlight certain areas in the prostate that might look irregular, it might be suspicious for prostate cancer, that are not in the standard areas that we can easily reach with a standard biopsy. So there's a technology known as MRI fusion biopsy where we can target those hard to reach areas and so perhaps get a more accurate, more specific type of biopsy. Also, for some patients who have a diagnosis of prostate cancer, sometimes we can use an MRI to more accurately continue to stage them and monitor them so we can see, are they progressing or not. And in general, those are the two ways that we use MRI.
Right. Okay. Well, some really great information. Thank you for sharing your time with us. Are you going to be running in the race this year?
I'm not around this weekend, so I
no.
feel bad for not being able to continue on.
You will be there in spirit.
That's right.
Well, we hope to see you out there on June 10th at Dunkin' Donuts Park to walk or run in that race, really to support prostate cancer, to create awareness. The money, of course, goes to a good cause in research and clinical trials when it comes to prostate cancer. So once again, thank you for joining us for this Facebook Live discussion. I'm Hartford Healthcare's Tina Verona. We'll see you back here next week.